All right. Hello, everybody, and welcome to the American Academy Sports Physical Therapy podcast series. My name is Michael Zarro. I'm an assistant professor at the University of Maryland School of Medicine, Department of Physical Therapy and Rehabilitation Science, where I spend much of my time teaching in our DPT program on the topics of anatomy and musculoskeletal rehab. I also see patients. I'm one of the team physical therapists at the University of Maryland in College Park and University of Maryland, Baltimore County, where I'm part of a team that takes care of our student athletes in the sports medicine department. With me today is Dr. Ekeke, and I'm going to pass it over to him for a brief introduction before we dig into our topic of management of rib dysfunction in athletes. Dr. Ekeke.
So thanks, Michael. My name is Dr. Ekeke. I'm a thoracic surgeon at the University of Michigan. I'm an assistant professor as a part of the Department of Surgery and section of thoracic surgery. I've been in practice for a little bit over 2 years now, and I originally trained at the University of Pittsburgh, initially as a part of general surgery, and then transitioned to the integrated cardiothoracic program. So thanks for having me, Michael.
Excellent. What I'd like to do today before we dig into our topic of rib dysfunction is just talk a little bit more about your current clinical practice, not only where you work, but the type of patients that you see, and then we'll pivot a little bit more specifically to rib dysfunction in athletes.
No, absolutely. So my practice is very, I say, like very polymathic, and so I see a huge breadth of thoracic and chest wall related disease, ranging from cancer, esophageal cancer, lung cancer, airway cancer, metastasizing disease, to benign disease, paraesophageal hernias, slip rib dysfunction, first rib syndromes, traumatic rib injuries, pectus, excavatum. And so I take care of a large breadth of disease, and it gives me a lot of access to patients from different demographics and different backgrounds. And so my passion for chest wall specifically really started with my love for sports. I'm a huge football, basketball fan. Going to the Ohio State University for college and med school, and now here at U of M, I always get the jokes of being in this very interesting conflict of sports allegiance. And so I have a huge passion for sports. And during my first few years of practice, I realized that the younger demographic tends to be almost missed when it comes to chest wall disease. And the data and the algorithms for the care is a little less straightforward. And so a part of kind of helping the great people of Michigan and others is investing in this disease process and also learning more about the treatment and giving that and delivering that part of care to my patients.
Excellent. What percentage of your caseload would you say is rib dysfunction versus some of the other diagnoses that you mentioned?
Yeah, that's a good question. Uh, I would say on average, if I see, 80 to 100 people a month in clinic, I would say for every 100, maybe 10 to 15 of those patients may have some element of chest wall dysfunction. Okay. And I would say of that, 15%, probably a third of that 15% would like to go to the operating room. And a lot of that is based on appropriate diagnosis, triaging is very important, and really knowing who will actually benefit from our operation. And I think that's where collaborative discussions around cases is very important because especially in the chest wall case, and for benign and malignancy for that matter, multidisciplinary approach to care is very huge, and not only selecting patients who will respond well to treatment, but those who will benefit long term from the care that you provide, along with the services that you are working with as well, whether it's physical therapy, oncologists, the whole team, the whole team approach to the care, patient response, not just to what I do, but to what they do as well, plays a role in that.
Excellent. So when we're talking rib dysfunction, a few different diagnoses come to mind. Can we dig into specifically slip rib, which is the focus of our talk is going to be? Let's talk a little bit about how you diagnose that. What are some things that go into the clinical examination? What is the role of imaging?
Yeah, so slip rib syndrome developed as a passion of mine. I'll say earlier this year. When I was in training, we didn't see a lot of those, but since starting here, I've seen quite a few. And I feel like this is an area of investment for me to really help people get through what I call an elusive diagnosis. A lot of the patients, when they come in for evaluation, most of them have had the $20 million workup. They've had multiple CT scans of the chest, abdomen, pelvis, multiple MRIs. They've had ultrasounds of their abdomen. A lot of them have had previous gallbladder removals because, this the presentation can be very similar to gallbladder disease. Several patients have been treated with antibiotics because sometimes pneumonias can disguise itself as slip rib syndrome. And more importantly, and unfortunately, a lot of these patients are on chronic pain medication because they've had this debilitating pain that doesn't allow them to participate in sports, work, and just function day to day. And so, other diagnoses that can look very similar to this is if you break it up, musculoskeletal, traumatic injuries can look this way. Fibromyalgia can look very similar to slip rib syndrome. And costochondritis can look very similar to slip rib. If you look at like the visceral, it's a lot of the visceral diseases, again, gallbladder, pancreas, disease of the spleen can look very similar. Hernias can look very similar. So a lot of patients see general surgeons. A lot of them see neurologists because sometimes neurologists can present very similarly. Patients who've had shingles, as far as like the dermatome distribution, all those different differentials can mask itself as slip rib. And so, because of that, a lot of these patients come with a huge workup and several medications that doesn't necessarily help them get better. And I would say, arguably, very few of them get physical therapy evaluation. And I'll also add on to that that the few that I've seen that have benefited from surgery, a physical therapist has seen them prior and had the initial concern that it was slipped rib.
So if a lot of these patients have kind of been through the ringer before they get to your hands and they've already had a variety of imaging, occasionally previous experience with physical therapy, in your hands, what is the gold standard diagnosis? Is it a diagnosis of exclusion, or are there certain criteria that you say, if X, Y, and Z are positive, I can firmly diagnose slip rib syndrome?
I would say it's a mix of both because there's so many other masking differentials. It almost by default becomes a diagnosis of exclusion, but this is essentially a clinical diagnosis. What do I look for before feeling confident that this patient has slip rib? Speak less of benefiting from whether it's conservative therapies or surgical management is one, I always diagnose or rather use a diagnostic ultrasound. Okay. And usually we call that a dynamic ultrasound, looking at how the muscles move, how the ribs move with provocative maneuvers. And so that's a very focused, specific type of ultrasound. And I think it's very key on how you order that because that's different than looking at an ultrasound for gallbladder disease or kidney stones. Another diagnostic tool and therapeutic tool is intercostal blocks. And so a lot of patients, I do offer getting intercostal injections once to see if there's any sort of relief, but also it helps you understand, okay, hey, people who have a positive response to the injections tend to do better with surgery. And so that serves as a diagnostic slash therapeutic adjunct for this sort of disease. And I would say more importantly, the physical exam. What we call the hook maneuver, basically you're sliding your finger underneath the offending rib and trying to hook that costal cartilage upwards and outwards, so superiorly and anteriorly, to kind of elucidate that tender response. Also, chest wall palpation. A lot of patients respond very aggressively to just aggressive palpation as another sign. But the hook maneuver is almost like the quote unquote gold diagnostic exam or diagnostic tool to really pinpoint this disease. And so I look at ultrasound findings, response to intercostal blocks, the hook maneuver, and most importantly, a very thorough history. And it is very easy to default to looking at all the images. Okay, hey, everything is negative. There's nothing for me to do. I look at, is there any previous or traumatic injury? Do you play sports? Again, I see this in a lot of the patients who are in their late teens, 20s, early 40s. And so, athletic history, car accidents, especially falls. And it's not so much one incident, it could be multiple injuries to that site. Patients with connective tissue disorders, Ehlers-Danlos, those patients are also at risk for these kinds of disease processes. And so I think a very thorough history is very, very important to really figure out, okay, hey, what am I dealing with and working with? And sometimes slip can happen bilaterally. Okay, there's a huge misconception that it's only a one-sided issue, but it could be in both sides of the chest. And so a important physical history and physical is very key to pinpointing this disease.
Excellent. Would you say there's particular sports or movement patterns that you say either predispose individuals to this type of problem or that you see most commonly? In my head, I'm thinking about sports where there's a lot of unilateral rotation or sports where some natural asymmetry is almost part of the sport, potentially a crew athlete who is predominantly in one seat in the boat and they're always reaching or rowing or rotating toward a particular side. What's your experience there?
No, that Michael, that is spot on. A lot of the exacerbating provocative maneuvers is a lot of trunk core exercises, twisting, turning. Even when you're driving, a lot of people like to turn all the way around to look towards the back. Those can be exacerbating behaviors. And so, sports specifically, I think about football, I think about basketball, I think about even gymnastics, right? And so, a lot of those trunk heavy, core heavy exercises can exacerbate those symptoms. In a lot of cases, patients have a hard time walking because of that. And so those are things that I look for. Even with previous traumatic accidents, like car accidents, hey, what side? Do you recall, shortly after the accident, when did you start noticing your pain? Is it worse when you sleep on your side? Is it worse when you wake up in the morning? And what's your response to pain medication? What have you tried? And so all those key details are very helpful in pinpointing areas of exacerbation and how to help the patient.
Excellent. So you mentioned positive response to a block being one of the potential indicators for surgery. Tell me a little bit about your treatment algorithm. Is every patient in your office, let's say by the time they get to you and you've gone through a thorough examination, you feel confident in that diagnosis, if they have a positive response to a block, are we scheduling them for surgery right away? Are we considering other non-operative management strategies first or in addition to? So helping me
Yep.
understand a little bit your algorithm.
That's a very good question. So when they come to me and after we've gone through the history in good detail, and I have a good sense that this is slip rip, most people do not have a dynamic ultrasound at the time of my evaluation. They may have a block, but not the ultrasound. So I'll always get the ultrasound without hesitation. Depending on where the block was done, I may repeat the block. Some people come in with a block that was done 2 years, a year and a half ago, and don't necessarily recall the response, um, or they've had a block before, but they've done maneuvers or life has happened to them where the symptoms have become exacerbated. And so I have a dedicated team here that does the blocks almost routinely, and that helps, right? I think taking out the variability in the people who are involved in the diagnostic workup is also essential to getting very similar outcomes as far as how your patients perform and and the answers you get from your testing. So, so I go for the ultrasound. They have a block that's not been done in the past 6 months. I get a repeat block. Okay. Obviously, the exam at the time of evaluation is very key for me. And if they don't have updated imaging within the past year, CT scan and MRI, I do repeat those because you want to make sure everything is rolled out. Okay. Again, costochondritis, some of that inflammation and edema around the costal cartilage can show on the MRI. And I've seen in my practice that patients don't respond as well to surgery in those cases. In fact, you may actually exacerbate the inflammation by doing an operation. And so that's where it becomes very, very tricky. And so those imaging studies help me rule out other causes of disease. But more importantly, after I get all that completed, I do have to go to PT for a lot of the patients, anywhere from 3 to 6 months of physical therapy to just get them conditioned for the operation. And the physical therapy, a lot of what they do ranges from manual compression, just different exercise prescriptions, from massages, helping just reduce inflammation, um, coaching on reducing and limiting provocative maneuvers to lessen pain. I have them go through that step because it's also a way to get people committed to their care. When it's very important that and not only diagnosing and discussing treatment, you want to give the patients also agency to participate in their care. And that's why I think getting PT involved is very important because that's the buy-in that I need, that everyone is on the same page and committed to doing well, not just for the operation, but long term. We want a solution that will help them long term, come off narcotics, come off long-term pain medicines, reducing unnecessary trips to the ED, right? But that requires a team-based approach with the patient at the center.
So thank you for saying those things. As a physical therapist, we love when our surgeons, see us as partners and want to utilize our ability to help a patient develop agency in their care and help determine things or address other dysfunctions that are present either preoperatively or perioperatively. Speaking from my experience in seeing patients with this diagnoses or even other chest wall related conditions is, I think pain in the rib region can affect so many different movements. And so we're likely
Absolutely.
to encounter patients who have concordant neck pain, shoulder pain, back pain, thoracic spine pain because of either kind of secondary or compensations or changes in the way this athlete is participating in their sport as a way to try and self-limit the problem. And so you may end up developing other difficulties or problems. And so that might be something where, as a physical therapist, we can help kind of weed out what is directly related to the rib problem, what is kind of a down the chain or kinetic chain type of problem. So some of the things that I think are worth considering, you mentioned manual therapy, and so mobilization of the thoracic spine or the costovertebral joints could certainly play a role in reducing inflammation or improving mobility of these segments. Soft tissue techniques to the nearby intercostal muscles, the oblique muscles, all of the muscles and connective tissues and fascial structures that have attachment to the rib, and certainly thinking about how we reduce tone in those muscles, I think can go a long way to try and restoring as close to normal rib mobility as possible,
Exactly.
in the setting of preoperatively, or to potentially try and see if an athlete could finish their season and consider surgery in the off season, or if potentially their goal is to reduce their symptoms and consider the surgery at a later date. But there's
Exactly.
certainly postoperatively, and imagining, related to the incision, these are athletes that are going to need continue to work on breathing training, and so there's techniques that
Exactly.
we have, inspiratory muscle training, facilitation of the appropriate segment that's likely going to be restricted postoperatively, and then attempting to resume as close to normal chest wall excursion as possible. So kind of piggybacking off that, can you talk a little bit about the surgical approach? How many incisions, where are the incisions? That way we can kind of paint a picture for the audience of what type of postoperative scarring and restrictions we're likely to
Yeah.
encounter.
No, it's a very good question, Mike. So the surgical approach is usually about a 45 centimeter incision, usually interior, okay, very close to where the eighth, ninth, and 10th rib, the false ribs, meet along that cartilaginous junction, and almost erring to the side of the obliques. We don't get into the obliques, we don't get into the abdomen, but almost a horizontal incision so that the exposure is sufficient enough to really look at eighth, ninth, and 10th, and sometimes the 11th rib. And during that time, the patient is usually laying, supine with a small bump up just to kind of get the that part of the chest wall elevated into view for the surgeon. And so, but it's very cosmetically nice for the patient, not a huge scar. And it usually involves us, mobilizing or first off assessing, okay, what's the actual slipped rib? When the patient is asleep and kind of, knocked out, you really have a way to assess the mobility of the offending rib. And it becomes pretty obvious at the time of the operation. And so we actually use a part of the cartilage as a buttress between the offending rib and the rib below, because ideally you want to have a fixed and stable chest wall at that region. You want to reduce the hypermobility of the offending rib while maintaining stability of the ribs above and below the offending site. Right. So we want stability. That is the key. So reducing mobility and promoting stability. And so we do that by using a piece of the cartilage from the offending rib, and we also use bioprosthetic plates, so absorbable plates. They usually go away within 9 months to 1.5 years to promote that stability until the scarring kicks in. And it's a huge difference after the operation when you notice that, okay, you don't have as much laxity and that subluxation is completely reduced after the operation. And I do tell the patients, you will feel pain after the operation. It's equivalent to a major orthopedic joint surgery just in the chest. And so I put them on very, very regimented pain medications, a lot of ice, a lot of massages, and I see them about every 3 to 6 months and kind of look at their process. And by seeing them every 3 to 6 months, you're still coaching them. Hey, you'll have pain from the surgery. You will have transitional pain. You have pain from the scarring, right? So limit constipation, limiting those provocative maneuvers. And usually around month 6, month 9, you start to dial up their physical activity, working their sports regimen, and around that time, you get PTC them a little more aggressively around that time because the scarring is already kicking in. And the plate that you use has time to settle. So those are very key, but the incision is very small. It heals very well, and a lot of patients do respond well to this if selected appropriately.
Got it. You mentioned a little bit about the timeline, about some of like the initial healing, and then as far as when the surgery, the plate is taken hold, and then kind of the return to sporting type timeline. But let's talk about those a little bit in phases. So let's just say those first 1 to 3 months. What do these patients look like? Are they what physical activity is appropriate for them during those first 1 to 3 months? Are these patients that are still, potentially needing to self-splint or do any sort of stabilizing to try and limit their pain? So what do these patients typically look like when they've come back for their first post-operative visit to you?
No, absolutely. Great question. So during that first post-operative visit, usually, 2 weeks after or a month after or 2 months after, and self-splinting, I'm still promoting use of ice. You're transitioning from needing narcotics like, okay, PRN, Tylenol, PRN, ibuprofen, but really you want to promote that scarring. I promote cardio, but more importantly, reducing core exercises, limiting constipation. If they're smoking, which has been discussed before surgery, that should be out of the question. We know that smoking reduces pain or reduces wound healing. Okay, but really promoting cardio, upper extremity is fine as well. But really, really cautioning patients on limiting core and twisting motions that can exacerbate the repair or rather worsen the repair.
Gotcha. So in this phase, within reason, some degree of cross training might be appropriate. At what point could an athlete, I guess, when do you give the athlete the okay to then begin to ramp up their physical activity? Is there anything in that kind of next 3 to 6 months phase that we can kind of ballpark as either appropriate functional activities or kind of criteria to progress into those next phases?
I still am an advocate of being more conservative during that time period because again the plate is still taking hold depending on the nature of the operation. If you're active football player, that trajectory may be a little bit differently because you're getting tackled. You're at risk for actually re-injuring and the slip rate becoming a recurring thing. Um, the sports that are not very trunk heavy or core heavy, there's a little more leniency in those patients. But the first 3 to 6 months, I'm very conservative. I mean, just do what you need to do to stay conditioned and not be out of shape. But we cannot do exercises that really stress the core or promote a lot of trunk maneuverability. But usually around not month 9 to 12, that's when we can slowly ramp up exercises. With that being said, Michael, this is where physical therapy becomes very important because you guys have the bandwidth and the skill set to know how to get patients active and coach them on, hey, what this is what you can do to stay on top of things without compromising your operation, right? And by having that coaching over the first 3 6 months, even to the 9 month mark, when they're ready to ramp up, they're not going from 0 to 100. It is a gradual but cautious increase in activity while still allowing them to perform. But I tell patients you need a good 9 to 12 months to get through this.
Got it. So I think sometimes one of the barriers to surgery, minus a life-threatening or debilitating need or a significant trauma is, many athletes are fearful of this kind of long recovery period. So how do you counsel your patients when they're in the office where they say, Dr. Ekeke, I am in severe pain, but I'm trying to play and
Yeah.
I'm trying to get recruited for college, or I have the potential to go pro, or my sport is so important to me, I don't want to stop. How do you counsel them on the potential of a 9 to 12 month recovery where they're very likely going to miss at minimum one season and have a limited training potential to get ready for the season after that?
Yeah, that's a very good question. It's hard, as someone who loves sports. I used to play when I was younger, and being told you can't do anything, is almost the biggest insult. When you've committed, your many years of your life to be better at your craft. And so, for those patients, I really do promote conservative therapy. And believe it or not, a lot of them are not getting appropriate conservative management, right? A lot of them don't have physical therapists on board at the time of evaluation, and not using ice appropriately. And so, for a lot of those patients, they can get away with just, hey, good ice, reducing inflammation, being methodical about what exacerbates their symptoms. But it is a commitment. It is a commitment because, and it's hard because, depending on what you do, some people say, hey, you know what, I can do the conservative therapy as long as I need, right? But when you're talking about, hey, this is uncontrollable, I can't move forward, then that's where the decision is made. So, hey, can you commit to staying in shape and just limiting, certain exacerbated exercises for 6 to 9 months? And that's what they have to come to terms with that, right? Because what you don't want is, okay, hey, we do the operation and then you let them go and be their best, and it results into a re-injury. And now you've made the recovery a lot more challenging. You're talking about going back in, taking out old prosthetic. It becomes a huge challenge. So it is a discussion. It's not something that you have in one day. This requires multiple sittings.
And then, so long term, what is your prognosis for these patients post-operatively? Do we have good estimates on the return to play potential and the risk of recurrence if an athlete does follow the appropriate post-operative instructions that you outlined?
Yeah, so the literature cites anywhere from 70 to 90% success rate, in patients who do get surgical treatment. Now, if you're talking about specifically the athletic domain demographic, the data is very, very great. This is not an operation that's done every day. I would argue there are very few places in the country that actually do this operation because a lot of patients go undiagnosed, misdiagnosed, or they may flat out refuse surgery altogether. And so I wouldn't say there's a huge, robust case series or randomized controlled trial that looks at this. But I think part of me and my colleagues really championing this kind of work is to really pull our data and create protocols and create algorithms and really find out, okay, hey, who benefits from surgery, and then who benefits from early return to physical activity versus not, right? And so, someone who's 21 years old and is a rower versus someone who is 35 years old and is a software engineer, again, the post-operative discussion was very different, but the data has them together, and that's where doing this work is very important.
So the $1 million question is always, are these injuries preventable? We talk about so many different sports injuries, and there's a lot of effort being done to, reduce the risk of ACL injuries, to prevent concussions and things like that. Are there any preventative strategies to reduce the risk of developing a slip rib in the first place?
Yeah, that's a good question. So a lot of it, comes down to being mindful of, uh, just like any other, musculoskeletal injury, right? Being aware of your environment, being aware of how you move on the field, on the court, really being intentional about your warm ups and cool downs. That's one of the biggest highlights that I've noticed in my practice in literature is that, hey, people who are not really doing a good job and warming up to exercises, this is where that becomes an issue. Obviously, car accidents, people with connective tissue disease, those are risk factors for, in some cases, things out of your control. Like, no one walks around hoping for a car accident. But as far as the sports space is concerned, I really think the focus is on appropriate warm ups and cool downs, before and after workouts, as a big plus.
Excellent. Um, Last thing before we start to wrap up here, is there anything else you'd like the audience to know about slip rib? Are there other treatment approaches? Are there things coming down the horizon, advances in surgical technique, other things that we haven't gotten to that you want to share?
Yeah, I mean, I know there's a huge Facebook, social media following with slip rib and patients sharing their experiences, with the diagnosis and after treatment, which I think is very important. I think any disease process, having patients come together and discuss their experience is very important for people who are considering, treatment, whether surgery or not. I think secondly, the biggest thing I would say is advocacy. I think patients have to, speak up for themselves when they are undergoing care. Again, a lot of these patients have the $20 million workup. They've been seen through the system. They've been labeled as, crazy. They've been labeled as seekers. And so a lot of his patients say, hey, I've had this workup for many years. I've failed, pain medicine. I'm concerned about this disease process. Do you know someone that sees these patients? Right? Sometimes it is simple as asking for a referral to get help. And so that's why I really want to, advocate for my patients. Make sure that you really put yourself in a position and say, hey, I've gotten this workup, I've gone through PT, I've seen some benefit, but I need to see someone who see these people a lot to get the best care.
Amazing. Thank you so much for your time and sharing your insight. The last thing I'd like to do before we wrap it up is just go through 3 rapid fire questions, things a little bit outside the
Absolutely.
topic of medicine, hopefully some things that are fun. So my first one for you is, what's your favorite thing to do outside of the office?
So outside of work, I love spending time with my family. I have 2 boys and a wonderful wife, and I'm big on family. I'm big on my friends. I have guys from training, college, that we all make trips every year, and I'm a huge sports fan, and so love college football. I'm a huge Philadelphia Eagles fan, so I'm surviving the season so far. And I love basketball. I love watching Kevin Durant, and so I'm big into the sports space. So anything that promotes me watching live sports, time with family and friends, I'm a huge fan of.
Amazing. Piggybacking on that, what is your favorite place that you've ever traveled?
I really enjoy Toronto. Toronto's such a nice city. The food, the people. My last trip there was probably a few years ago, and it stuck with me.
Amazing. Awesome. Last one, what is something about the future of medicine or healthcare that has you excited today?
Healthcare is evolving so quickly now compared to how things were 20, 30 years ago. And so I'm more excited about where the pace is taking us. Much like the tech world where, every 5, 10 years things evolve. And now in this current era, things are evolving every year. And so I love seeing how healthcare is catching up and staying on pace with the evolution of how not just Americans, but how the world is transforming. And so, with the adoption of AI, the adoption of how electronic health records have evolved to be more patient-centered, I'm really excited about all those things, and also how we take care of patients is also evolving. And so, I'm just enthused about the evolution and the pace, but also making sure that we're good stewards of those resources and those gifts. And so, I love being in the mix of that.
That's really exciting to hear. Thank you so much for joining us today and sharing your passion and your knowledge about this topic. If anyone in our audience is interested in following up with you or keeping up with some of the things that you're doing, are you willing to share your social media accounts? That way we can link to them in the show
Yes,
notes and on
yes.
the advertisement for this.
Absolutely. Follow me on Instagram at Chigo Sharp, ChigoSharp. I have LinkedIn as well, EKKMD. And also my email is CEKE at gmail.com.
Dr. Ekeke, thank you so much for your time. This wraps up our podcast. On behalf of the American Academy of Sports Physical Therapy and the College and Professional Sports Interest Group, we thank everybody for listening.
Thanks, Mike.